Hello, everyone. I'm honored to be here. I'm Dr. Paola Pedrelli. I'm the director of the Dual Diagnosis Studies at the Depression Clinical Research Program and Massachusetts General Hospital, and I'm assistant professor of psychiatry at Harvard Medical School. What I would like to talk about today are three major areas. So first of all, I would like to review the findings of the association of mood and depression and heavy episodic drinking and alcohol misuse. Then I would like to review some of the processes that might explain this association or the co-occurrence of these two conditions. And then finally, I will review a treatment study that I conducted and some findings from that study, and also make some association with some finding that other labs have identified. So first of all, let's review why I think that it's important to talk about heavy episodic drinking among young adults and why I'm devoted a lot of my time to this topic. So heavy episodic drinking is defined as the consumption of 4 starter drink among females and 5 starter drink among males, and is a very common, unfortunately, behavior among young adults. And according to the Monitor Future study, which we can see a figure here, in 2017, 40% of young adults between 21 and 22 years of age actually reporting heavy drinking in the past month. And so this figure actually is interesting for a number of different reasons to me. First of all, because it illustrates very clearly how young adulthood is really the time when heavy drinking peak. So basically, because it's illegal, it's not very common among adolescents, then around 21-year-old, there's a very significant uptake of this behavior that is sort of maintained until people are around 30 and then slowly decreasing over time. To also understand a little bit more about this, I would like to present more information about prevalence of heavy drinking. So on the top of this slide, you can see data from the National Survey on Drug Use and Health that illustrated the prevalence of different drinking behavior in 2017. So according to data from the NSDUH, 20 million of young adults between 18 and 25 reported drinking any alcohol, so that's corresponding to 57% of this population. And then 13 million young adults, 18 to 25, reported binge drinking, which correspond to around 38% of that population. And around 4 million individuals had alcohol use disorder, that corresponded to around 10% of the population. So this is really big numbers that you can see. The sort of good news is that, fortunately, this behavior has been decreasing over the past 10 years, but we're actually looking at the past 4 years here. So on the bottom right, we have data again from NSDUH about alcohol use disorder from 2016 to 2019, and we can see that, fortunately, alcohol use disorder have been decreasing over the past 4 years. So we can see that in 2016, around 3.7 million young adults between the age of 18 to 25 met criteria for alcohol use disorder. And now it's in 2019, we're around 3 million of individuals. So basically we went from 10.7% to 9.3%. And similarly, also the prevalence of binge drinking over the past few years has decreased. And this is again a trend that we're not seeing here, but it's been documented that it's been going on for around 10 years. And so from 2015 to 2019, the prevalence of binge drinking in young adult 18 to 25 have decreased from 39% to 34%. Although the overall prevalence of past month binge drinking has been decreasing, it's also important to focus not on necessarily if it happens once a month, but how often. And unfortunately, we have seen that while 43%, around 40% of young adults engaging at least one episode of heavy drinking the previous month, around 22% almost engage in heavy episodic drinking almost once a week, and 13% in more than once a week. But again, why do we care about heavy drinking and why there's been so much effort devoted to reducing this behavior among young adults? Well, primarily it's because it's associated with a lot of severe personal problems and societal problems. So it's been estimated or documented that each year approximately 600,000 injuries are due to alcohol in this population, that approximately 700,000 students are assaulted by a drinking student, approximately 97,000 individuals are the victim of sexual assault in the context of alcohol use. And finally, it's been estimated that around 1,800 deaths can be associated with alcohol each year. And this number also are concerning, but there's also a number of other problems that are being identified in this population. So people have reported being physically sick and blacking out, people having school problems due to alcohol, they engage in sexual activity they regret later, they might be physically injured, they might be drinking and drive, and a number of young adults report getting into physical fight due to alcohol consumption. Young adulthood is also a time when major depressive disorders first appear. In fact, we can see data illustrated here in this slide. So the top of the slide indicates prevalence of major depressive episode over the past 15 years, so from 2005 to 2019, and the different line indicates different ages. And what we can focus is basically on the line that indicate the prevalence of major depressive episode among 18 to 25 years old individual. And the figure in the bottom just give more this information just with nice numbers so we can understand it better. Something that is very concerning from this data is that unfortunately the prevalence of major depressive episodes has been almost doubling over the past 15 years. So it has gone from 8.8% until 15%. And unfortunately, this is not something that has happened also in other ages. Like this is a prevalence that's been pretty stable, depression among 15 years older in other population. The fact that depression, unfortunately, is very common among young adults is something that has been found also by the American College Health Association. So they have reported in a survey that they conducted in 2015 that approximately 1 or 4 students reported being very sad in the previous 2 weeks, around 70% reporting feeling sad at least once in the previous year, and then 20% reporting feeling hopeless in the previous 2 weeks, and half of them reporting feeling hopeless at least once over the past years. Approximately 12% reporting feeling so depressed that they had a hard time functioning in the 2 weeks prior to the survey, and approximately almost 50% really reported feeling so depressed they had a hard time functioning. And then very concerning is the prevalence of suicide. So around 2% reported seriously considering suicide in the 2 weeks prior to the survey, and around 9% reported seriously considering suicide in the year before the survey. And finally, around 0.3% reported attempting suicide in the 2 weeks prior to the survey, and around 1% reported attempting suicide in the year before the survey. So given that the onset of both heavy episodic drinking and depression usually happens during youth, a number of people have been interested in determining, is it depression that leads to alcohol or alcohol misuse, or is it more alcohol consumption that might lead to depression, or is it a bidirectional association between alcohol depression, so that alcohol might lead to depression that might sustain alcohol consumption, leading to sort of a negative loop, a negative situation. So I've been interested in investigating more this question. So a few years ago, I conducted a review with some of my colleagues trying to tease this association. And specifically, we found that the association really depended on when they were examined. So basically at the age of the individual. And we found consistently that there was a strong association more among youth, but the association were less strong when we investigated a young adult or like adult. And secondly, it really depended also on the severity of the problem. So the association was found more consistently among depression and alcohol use disorder rather than initiation of alcohol use or frequency of heavy episodic drinking. So in summary, more specifically, what we found is that higher frequency of alcohol use and alcohol use disorder was associated with major depressive disorder or subpressure MDD during late adolescence. But there were really minimal evidence of heavy episodic drinking in adolescence leading to depression in late adolescence and in the young adulthood. And similarly, depressed mood during childhood and adolescence was associated with higher, more frequent alcohol using during adolescence and with alcohol misuse during adulthood. And finally, children and adolescents with worse depressive symptoms were at higher risk to report alcohol intoxication during adolescence and having a twofold increase in risk of alcohol use disorder in young adulthood. So while it's still unclear really the direction of this association, and people are still investigating these conditions and this relationship, people also start hypothesizing why depression and alcohol misuse really co-occur. And there are a few hypotheses that can be looked at. So first of all, these two conditions might have common risk factors, so they can contribute to the onset of both of them. In fact, we have seen that the same genes might contribute to the risk of developing both MDD and alcohol use disorder, so the same genes are involved in the occurrence of both conditions. There's been a consistent finding that stress can lead to both heavy episodic drinking and also major depressive disorder. And also, they both involve abnormality in the reward system. So abnormality in certain brain areas might actually lead to both the presence of depression and alcohol misuse. And finally, as we were saying, mental illness might contribute to substance use or to alcohol use disorder. And so, for example, individual in great distress with depression might resort to engage in alcohol consumption to sort of cope with a negative affect. And similarly, when a person develops depression, might experience some brain changes that might enhance the rewarding effect of the substances, and that's why they might start drinking heavily. And similarly, alcohol misuse may contribute to the development of mental illness in such a way that alcohol consumption might lead to brain abnormality that might then lead to depression. Given the importance of understanding the occurrence of depression and heavy episodic drinking, we also have examined this association in a large national sample of college students. And we observed that with regard to prevalence of heavy episodic drinking, consistent with other findings, we found that around 50% of the males reported heavy episodic drinking and 42% of the females. 1 of 5 males and 1 out of 4 females met criteria for major depressive disorder. And we found that around 1 out of 10 students had both depression and heavy episodic drinking. And again, with regard to actually the association, we found that having meeting criteria for major depressive disorder would increase the risk for actually engaging in frequent heavy episodic drinking. And this association was similar between males and females. But we found that also MDD put a higher risk for higher peak blood alcohol concentration, specifically in females and less so in male. In another study, we were interested also in the association between depression, suicidal ideation, heavy episodic drinking among cisgender and gender minority students. And as a reminder, gender minority indicates individual whose gender identity differ from the sex they were assigned at birth. In this study, we found that almost twice as many individuals who self-identify as a gender minority reported depression, which is very concerning, and in particularly individuals who were assigned female sex at birth but self-identify as a gender minority were at very high risk for major depressive disorder. So 72% of this population reported major depressive disorder. Similarly, also gender minority individuals were a higher risk of suicidal ideation, so twice as many reported suicidal ideation relative to cisgender individual. Conversely, heavy episodic drinking was more common among cisgender students relative to gender minority students. So around 38% of individual self-identify as a cisgender reported heavy episodic drinking relative to 26% of the gender minority students. And so with regard to the occurrence of heavy episodic drinking and major depressive disorder, the occurrence was more prevalent among gender minority students, probably because they're unfortunately more depressed. So 20% of them, they were engaging in heavy drinking and depressed, and 15% of cisgender students were reporting both depression and heavy episodic drinking. We were also interested in determining or examining whether heavy episodic drinking would increase the risk for suicide ideation in both cisgender individual and gender minority individual, and whether this association depended on sex assigned at birth. And we found that heavy episodic drinking was associated with a significant worsening of suicide ideation among the gender minority students. And in particular, this effect was particularly strong among those individuals with male sex assigned at birth. And of course, this is very concerning because, as we have seen, suicidal ideation is very prevalent in this population. And so it needs to really be addressed and investigated further. So we have seen that heavy episodic drinking and depression often occur. And so we've seen that oftentimes approximately 1 out of 10 students may have MDD as well as heavy episodic drinking. And again, with regard to why is this important to examine, we have seen now there's been more consistent studies showing that this co-occurrence is actually associated with a higher prevalence of alcohol-related problem. In fact, Shannon Kenny of Brown University reported that in a sample of 1,200 freshman students, higher depression was associated with higher alcohol-related problem, even when controlling for amount of alcohol consumption. And similarly, Ashley Denhard and James Murphy from the University of Memphis documented that there was a positive association between depression and a higher number of alcohol-related problems among both European American as well as African American students. And in a recent study that I conducted in collaboration with Samuel Akouf, also from Jim Murphy lab at University of Memphis, we found that baseline depression predicted problems related to specific alcohol-related problems. So specifically related to impaired control, so drinking more than planned, or self-perception and physiological dependence while controlling for alcohol use 12 months later. And in addition, worsening of depressive symptoms over 1 year was associated with increase in total alcohol problems, including impaired self-control, self-perception, self-care, academic, occupational problem, physiological dependence at 12-month follow-up. And so again, there's a lot of finding at this point that the presence of depression among those who engage in heavy drinking is associated with pretty significant and concerning alcohol-related problems. So to dig a little bit deeper with regard to depression, alcohol use, and processes that might be involved, we can see here how we can illustrate some of this association and some of these processes here. So negative emotionality is one of the 3 domains in the alcohol addiction research domain, which is an organizational framework for behavioral, neurobiological, and genetic research processes that might likely contribute to alcohol use disorder. So negative emotionality refer to negative states, including negative affect, anhedonia, anxiety, and also depression. And that can be the consequence of repeated alcohol use, but can also be the precedence of alcohol use. And so with this domain is being posited that depression might be associated with alcohol use through low self-efficacy, positive expectation of alcohol effect, and low coping skills, which might lead eventually to drinking to cope. So we might think that individuals with depression or negative affective states might have low coping skills to regulate their negative affect. They might anticipate that alcohol will make them feel better. They might have a low sense of efficacy, and then they might drink to cope with their emotion, which leads to alcohol misuse. Given the association between depression and alcohol-related problems, I was interested in examining also the processes that might mediate this association. And so we found in a study that we conducted a few years ago that depressive symptoms, of course, as we have seen at this point, are associated with alcohol-related problem. Oftentimes, this association is mediated by coping problems, coping motives. And I was really interested to see the role of gender in this association. And in this study, we found that in females, coping motives was mediated by heavy drinking. So in women, depressed women, they drank to cope, they drank more heavily, and the heavy episodic drinking led to alcohol-related problem. And this was not the same, though, among men. So women have more physiological effect of alcohol in engaging behavior that may be later regret, or the heavy drinking might affect their academic performance. However, again, this is not something that we found that occurred in male students. Another factor that is related to negative emotionality domains is the construct of distress tolerance. Distress tolerance can be classified as perceived distress tolerance, so what people think is their ability to withstand stress. So I'm thinking that I really can withstand any sort of stress. Something might be very unbearable to me. And also a behavioral distress tolerance. So it was actually the actual behavior of continuing to endure specific stress. And perceived distress tolerance is being measured more by self-report questionnaires, because it's more like, again, my perception of what is my ability to withstand stress, whereas behavioral distress tolerance is being more measured by experimental setting, where an aversive condition is elicited, and then the time or the ability of individual to withstand that condition is considered the index of their behavioral distress tolerance. Studies have been presented a little bit of a few mixed finding with regard to the role of behavioral distress tolerance in heavy episodic drinking. And so I have examined a little bit more of this association, and we looked at the role of behavioral distress tolerance in heavy episodic drinking in young adult, and I looked at whether gender had a role in it. And so we looked at both behavioral distress tolerance indexed by the time student would persist at a mathematical task that was distressing, and also we looked at emotional reactivity, basically that was measured as the change in affect in the context of an aversive situation. And as illustrated in this figure, we found that women with low distress tolerance, so women that would not persist at the task or would quit the aversive task, tended to have more heavy episodic drinking. But the same result was not found among male students. And with regard to emotional reactivity, we found that how much people react, the intensity with which people react in aversive state was associated with heavy episodic drinking. So the more the individual reacted, the more likely they were that were actually engaging in heavy episodic drinking. With regard to more the perceived distress tolerance, we examined the association between distress tolerance and coping and alcohol-related problem, and the role that coping had in mediating this relationship. And specifically, perceived distress tolerance has been classified as including different subscales. And so specifically, the distress tolerance scale has a number of different subscales. And so there's a tolerance subscale that indicate or measure the ability of individual to withstand their distress. And so, for example, one item can be, I cannot handle feeling distressed or upset. Then the appraisal subscale indicates or measure subjective appraisal of distress. So how one judge their distress. So my feeling of distress or being upset are not acceptable. The absorption subscale refer to the tendency to have one's attention absorbed by the distressing event or stimuli. So someone at one of these items is, when I feel distressed or upset, all I can think about is how bad I feel. And finally, the regulation subscale assesses more the strategy that the individual use to regulate the distress. So when I feel distressed or upset, I must do something immediately. So basically they're distracting or doing something to not really focus on the distress. What we found is that while distress tolerance and all the subscales of distress tolerance were associated with alcohol-related problem, only drinking coping with mediating only the association between the appraisal subscale of the perceived distress tolerance and alcohol-related problem. And we found that perceived distress tolerance was not associated with heavy alcohol use. So ultimately, what we would like is really to help individual with depression and heavy episodic drinking. These are distressing states that are associated with a lot of problems. And so I think it's important to look at prevalence of treatment, what treatment can be, and how we can use these individuals. So while mental health problems are common among college students, many students do not seek help. And as we can see from these figures, so the top table indicate the prevalence of how many students with major depressive disorder actually sought help in the previous year. And so these are data from 2009 until 2016 and is somewhat consistent, but basically around 44 to 47% of individuals between 18 to 25 sought help in the previous year. Notably, this is not ideal, but at least we have almost half, 50% of young adults who seek help. what is actually very different. Individuals with frequent heavy episodic drinking without depression don't really seek treatment. So how we can see from data collected from Crankford and colleagues, we can see that among students who were engaging in frequent heavy episodic drinking but did not have depression, only 14% sought treatment. Conversely, the students who were engaging in heavy episodic drinking and also major depressive disorder sought treatment more commonly. In fact, 58% of them sought treatment. The low treatment engagement among people with heavy episodic drinking is something that's also been reported by others, like Blanco, who reported that only 5% of young adults with alcohol use disorder sought help. And so this highlight that there's a really big difference in treatment engagement or treatment seeking between young adults with depression and young adults with only heavy episodic drinking. So it's really important to identify strategy that would increase engagement of students with mood problems and heavy episodic drinking. So in Cranford study, it was not really clear whether the presence of heavy episodic drinking among those who had depression had an effect on treatment seeking. And so in a large study where we survey individuals from a number of different colleges across the United States, we examined the association between depression, heavy drinking, treatment engagement, and the role of gender also in all these associations. Consistent with previous funding, we found that those with major depressive disorder sought treatment more relative to those with heavy episodic drinking. And also consistent with previous finding, more females with major depressive disorder were in treatment. So we can see that 1/3 of the women with major depressive disorder were in treatment relative to only 24% of the men, and only 15% of the women with not major depressive disorder were in treatment relative to 10% of the men. Also, heavy episodic drinking had a little bit of an effect among women. So 1 out of 5 women reported seeking treatment in the past year who had heavy episodic drinking, and 13% of the men with heavy episodic drinking reported engaging in treatment. We did a 3-way interaction. We conducted a 3-way model looking at depression, drinking, and gender predicting engagement, and we found that that was not significant, and heavy episodic drinking did not increase treatment engagement. So basically, people who had both depression and drinking were not engaging more in treatment than those who had only depression. So to review, we have seen that heavy episodic drinking plus depression is associated with an increased risk of alcohol-related problem. We have seen that there's unfortunately a very low treatment-seeking behavior among those with heavy episodic drinking. And something that I haven't reviewed, but it's true, we have found that has been reported that brief motivational interviewing, which is the intervention that is most commonly used with young adults or college students who have either been caught drinking on campus or they're going through the judicial system. Well, BMI is associated with very small effect sizes, and it doesn't seem to work for depressed women. So it becomes apparent that there is a need to develop a treatment for students with depression and drinking and heavy drinking, because again, the treatment that are currently available might not really work for this population that is a higher risk for problems. So what we decided to do is to develop a treatment for this population that combine cognitive behavioral therapy and brief motivational interviewing. And there's a few line of finding that suggested that this was an appropriate choice. So first of all, we know that CBT is effective in treating depression. There's a large amount of information that suggests that MI is effective in reducing alcohol use. And we also have seen that the integration of MI and CBT is feasible. Other studies have conducted that, and NIAAA had recommended combining CBT-MI for alcohol use, so suggesting that this is an appropriate direction to go. So we conducted a study where we compared the effectiveness of a treatment combining CBT and BMI versus a treatment that included only CBT. We randomized people to one of these two conditions. All the students were delivered a session of therapy and were assessed immediately after completing therapy and a month after the completion of treatment. We use a generalized estimating equation to assess changes in symptoms. And so we looked at depression, drinking, and alcohol-related problem. And you can see here on the top that drinking decreased significantly across the assessment for both group. So there was not an effective of treatment. So the two treatment performed pretty similarly, but there was an effect of a time. This is also what we found with regard to depressive symptoms. So on average, students in both condition improved across time, and there was not really an effect of treatment. And similar results we found for alcohol-related problem. So basically on average, students went from experiencing a little bit more than 5 alcohol-related problem over the previous 4 weeks, and then they decreased to around 4 in the previous month. We were also interested not only on significance decrease, but also in whether the decrease had a clinical implication or clinical effect on people's life. And so we looked actually at the percentage of students who recovered and how many actually had a reliable change in the depressive symptoms. And so if we pay attention to the recover proportion, so approximately 50% of the student actually recovered in the context of treatments, around 56% in the CBT condition and 46% in the CBT BMI condition. And this is something that was maintained at the follow-up. And also with regard to reliable change, we could see that approximately 53% in the CBT condition and 46% in the CBT and BMI condition experienced a significant improvement in the context of treatment, and also 50% maintained this improvement. Notable is around 30% reported no change. So 34% in the CBT condition, 37% in the CBT BMI condition, and also a follow-up 43% for the CBT and 33% for the CBT BMI. So there's still room for improving this approach. As we have discussed previously, we have seen that there's an association between depression problems and alcohol use. So we were interested in looking more at the processes that might mediate this change or this improvement. So we looked at whether improvement in depression would lead to improvement in alcohol, improvement in alcohol would lead to improvement in alcohol-related problem, and similarly, if improvement depression would improve alcohol-related problem. And so we conducted a number of mediation analyses, and we found that change during treatment, so improvement of depression, actually led to improvement, a reduction of alcohol-related problem during the follow-up period, and a reduction of alcohol-related problem in the context of treatment also led to a decrease in heavy episodic drinking at the follow-up phase. And also we look at specific processes. As we have seen, there's emotion dysregulation and coping skills are associated with drinking. And so we were interested to see whether the treatment were acting on any of these processes. And so what we found is that the improvement of drinking to cope, so reduction of drinking to cope, reduction of avoidance coping, and improvement of reappraisal skills then led to a lower depressive symptoms, and also a reduction of drinking to cope led to a reduction of alcohol-related problem. We didn't find this process be involved with the reduction of heavy episodic drinking. So in order to understand further our finding, we also conducted a network analysis of change scores. So just to orient you, all these nodes are indicating change in the positive direction of different constructs. So we look at sadness, we look at loss of interest in people, like anhedonia, loss of energy, drinking to forget your problem, alcohol-related problem, and a heavy episodic drinking. And so each node indicate a change in these areas, and the edge of this line indicate relationship within these nodes, and the thickness of the edge indicate the strength of the relationship. And so we found that in the change score network, including this treatment as a node, frequency of heavy episodic drinking and loss of energy demonstrating the highest strength centrality measure. So basically were the nodes that were more central and more connected to the other construct that we investigated. And the treatment node had a positive association with both drinking to cope and the loss of interest in people, indicating that had a positive effect on this area. And specifically, when we looked at this effect, we looked at the combined intervention of CBT and MI exhibited a greater reduction in drinking to cope motive and an improvement in loss of interest relative to those who received CBT alone. And also to continue to maybe attempt to understand a little bit our finding, we compared our effect sizes with other studies and just to understand a little bit more the context of our findings. So to review, with regard to heavy episodic drinking, we found small to moderate effect sizes, so around 0.5, 0.4 at the first follow-up, and then 0.3, 0.7 at the second follow-up. We can compare this finding with the study conducted by Kenny from Brown University, and she found that there was actually no change over time of heavy episodic drinking among college students that she tracked 1 month and 6 months later. And also, Carey found that brief motivational interviewing had a very small effect size on heavy episodic drinking, around 0.17, 0.11. And so this finding actually suggests that drinking is actually a pretty stable behavior. And so the change that we found maybe were due to treatment. And then, however, if we compare our finding with the study conducted by Jim Murphy at University of Memphis, where they looked at brief motivational interviewing plus an intervention that's called SFAS, that's called basically substance-free activity session. And this treatment is really focused on increasing the saliency of delayed goals. We found that BMI plus SFAS or BMIs plus relaxation was associated with large effect sizes, but also the assessment only condition was associated with some changes. So it's really not clear at this point whether the changes that we found in the context of treatment were due to treatment or just the passage of time. We also looked at the effect sizes of depression for depression of our study and also Jim Murphy studies. And we found pretty significant large effect sizes of 1.2, 1.5, 1.7 for the follow-up. And they found that the BMI plus SFAS condition was associated with an improvement of 0.45 and 0.29, and BMI plus relaxation also had a small effect sizes, but also notably, they were not really focused on changing depression. So together, our study and their study seems that there is a positive effect that we can have on both drinking and alcohol. I wanted to just talk a little bit more about our finding and the finding that was documented by Jim Murphy. So it is notable that our study, the CBT study, was really focused on identifying goals for the students, and they often were goals that were related to healthy behavior or to academic behaviors, and then identify strategy that would help them attain their goals. And this is actually similar to what the SFAS intervention is focused on, to basically, again, elicit specific goals of the students and then make them very salient and motivated to pursue these goals. So it seems that it's possible that students' reduction of drinking and reduction of depression and reduction of alcohol-related problem might be facilitated by a reduction of drinking behavior and engaging in activities that are inconsistent with drinking and in order to pursue future goals. So together, all this study might suggest that it could be a similar model explaining the negative emotionality in college students. So we might have the depression might be associated with alcohol misuse and alcohol-related problem. This association might be mediated by this emotion dysregulation, inadequate coping or low coping skills, or drinking to cope motive that then leads to alcohol-related problem and alcohol misuse. And then it seems that specific treatment that reduce depression, so there's nothing to cope with because people are not depressed anymore. So reduction of depression, reduction of drinking to cope motives then might lead to benefit for depression and alcohol and alcohol-related problems. So where do we go from here? So I think that all this findings suggest that we need better identification of different disorders. So individuals who have been maybe identified for heavy episodic drinking, they should also be screened for mood disorders and vice versa. And I think that there is a very exciting development of new technology that could be leveraged to understand better this association. So studies looking at passive monitored could really help us understand even more the relationship between mood and heavy alcohol use. And I think it's going to be very important to continue to develop and disseminate evidence-based intervention that are shorter and might increase treatment access. So that's still a problem that a lot of students with mood problem and drinking problem do not seek treatment, and they continue to have this behavior consistently for a long time. As I just briefly said, I think it's very important to continue to examine the role of gender in all these processes and behaviors and conditions. And finally, again, with regard to treatment, I think we need to continue to develop precision medicine. And so maybe by developing just-in-time adaptive intervention, identify trigger for alcohol use, and develop intervention that might act upon the time that is more important. In conclusion, I would like to thank all my collaborators, the Depression Clinical Research Program, and also I would like to thank support that I've received from the National Institute of Mental Health and from the National Institute of Alcohol Abuse and Alcoholism. Thank you very much.